Hello to you all. I'm Michelle Walder and I'm the chair of the Migraine Trust, and it gives me particular pleasure to welcome you all to today's public session. This is our first virtual international symposium and we're delighted to welcome so many of you. I've been chair at the Migraine Trust for around 18 months, but the Trust itself has been doing the vitally important work of supporting those affected by migraine for over 55 years. Last year, in 2019, we joined forces and resources with Migraine Action. And this means that we're now the only national support and research charity for those affected by migraine in the UK. And people affected by migraine are at the very core and the heart of our charity. The Migraine Trust has a straightforward mission. It's to fund and promote research. It's to provide evidence-based information and support to those affected by migraine. And it's to campaign for change in the belief that there will one day be a cure. And this is an exciting time for both the Trust and the migraine community, with breakthroughs in treatment and increased understanding societally of the condition and its impact on people's lives. Earlier this year, in February, some might say dreadful timing, we launched our 5-year strategy. And this strategy was developed with our stakeholders and with the migraine community, and it sets out how we will support people with migraine going forwards, increasing the number of lives we can improve, helping increase the range of our services that we offer, and always trying to advance migraine care and migraine understanding through research. Whilst it's been a challenging time, as it has for many of us personally, we have done our best, and the team on the ground have done their best to be creative around the way that we've continued to try and deliver against that strategy, even without some of the things that we would normally rely on, such as being able to meet people in person. The team on the ground, who are committed every day to delivering our services, and the Board of Trustees bring together medical and non-medical experience, insight, and input. We have excellent secondary care trustees in many of our medics. We have brilliant primary care trustees. And from our non-medical trustees, we bring over 200 years combined experience of management and leadership. We come from different sectors, different backgrounds, and we bring all of that together in order to best serve you, our community, the people affected by migraine. Many of you will have come across, or may have come across, or even used some of the services that we offer. Our information and support service provides evidence-based information and support around many, many aspects of living with and managing migraine, including diagnosis, treatment options, living with migraine, and supporting those who are supporting those suffering from the condition. We have an advocacy service which empowers people at work to engage with their employer around migraine and adjustments that might be made for that. We have a volunteer forum which currently numbers over 100 people, and they come together to provide insight to us as a trust, both in terms of the services that we're developing, but also the reality of living and managing migraine in real life. We also use the forum to support our work in terms of sometimes promoting it and sometimes raising money for us, which is a vital part of the work of the Trust. The other key aspect of the work that we do, in addition to information and support, is to advocate with NICE and SMC for migraine sufferers to receive new treatments and to bring those into more accessible spaces for us. We worked recently as part of the CGRP appraisals, which led to new treatments being available in England and Scotland. And this work is clearly vital for the migraine community. So it just leaves me to thank you very much for the time and your commitment to the Trust. I hope you have a productive and enjoyable session today. I'm sure it will be. And welcome. I hope you enjoy your day.
Hello and welcome to the Migraine Trust's 2020 public event program. My name is Peter Goadsby. I'm a medical trustee of the Trust. Today we're going to share with you some of the more exciting things that have happened at the meeting. Over the last week, and I'll just show you a slide to give you an idea of the breadth of what's happened, we've met virtually for the first time in the 18th International Migraine Trust International Symposium. The dark blue shows you a map of attendees from all over the world. And you can see, unsurprisingly perhaps, because migraine is a global problem, that we've had global attendance, more than 1,800 attendees from as far north, you might say, as Alaska and Canada, down to the tip of South America, across into Australia and New Zealand, up into India, China, Russia, back to Scandinavia, and down into Europe. We've had nearly little more than 2,000 views of our teaching course material. Our professionals are interested in learning about migraine and interested in helping patients with the problem to improve. What we've got today are the best and brightest who are going to tell you about what's happened and what the latest things are, and offer you the opportunity to be able to ask them questions. And with that, I'll hand over to Mike Wakefield, one of our trustees at the Migraine Trust, to move things forward. Thank you for attending.
Thank you, Peter. Good afternoon and welcome to this quite unique and unusual virtual migraine event. The way the day is going to pan out is basically we've got two separate sessions, and within each session we've got two separate presentations which will come one after the other. At the end of that, we're going to have a question and answer which will be made up of the speakers plus Professor Goatsby, and there'll be essentially a panel which will answer the questions which we are hoping everybody will submit. Now, the process for submitting questions is quite easy. You go to the right of your screen, you'll see an icon there. You can just click and then you can enter the question. That can be done anytime during the talks. So please do that, so we've got questions to start with as soon as we go into the session. We allocated good time for the questions. You've got nearly half an hour at the end of each session. So we believe we'll be able to cover everything very well. What we are looking at now is going straight into the first presentation by Dr. Louise Rusk. Louise is actually a trustee now of the Migraine Trust. She's also a GP in Ireland with a GP of special interest in migraine, and she leads a migraine clinic in Ulster Hospital. So I will hand over to her so that feed will start, and we welcome you all again and look forward to good presentations and lots of questions, and hope you all enjoy what is quite an unusual and new experience for most of us. Thank you and enjoy.
Good afternoon. Thank you to the Migraine Trust for the honour of speaking at today's Patient Day. I've been asked to speak with you about self-management, how to take control of your migraine and what you can do to help yourself. My name's Dr. Louise Rusk. I'm a GP with a specialist interest in headache, and I come from Belfast in Northern Ireland. This is where my GP practice is. It's in East Belfast, which is also the birthplace of C.S. Lewis, who is the author of the Chronicles of Narnia. And we have our iconic Harland and Wolff, cranes, Samson and Goliath. And so I work as a GP, and I've worked in that practice for about 10 years, but I also work in the neurology department in a district general hospital. There I run a headache clinic and see patients who've been referred from ENT, from following hospital admissions, from other medical specialties, and also from GPs. So it's from that background that I'm coming to you today. Bit of a Google search on migraine and control, and this popped up. It's a neat little article by Professor Goatsby and Shazia Afridi of King's College, looking at the fact that we're now thinking a bit differently about the triggers of migraine, may they be partly to do with the early changes in migraine or the prodrome? And I'm going to come back to that in a minute. But thinking about control, I thought about the pandemic that we're in at the moment, and there are parallels to be drawn here. Like migraine, COVID-19 is something that has been foisted upon us. It's biological, it affects people differently, and there's a lot about it that you can't control, but there is much that you can control, and we're all learning ways of adapting to be able to live our best life with COVID-19. I thought it would be helpful to go through this, this infographic from the Migraine Trust, and this is really outlining what a migraine attack is. People tend to focus in on the headache, and you know, everybody that's watching here knows that it's more than just a headache. And to come back to what I alluded to earlier about the premonitory phase, so I'll take you through each of these stages. The premonitory stage is something that happens before you get anywhere near the pain. It can happen for an hour to a day before, and people report changes in their mood, feeling more sleepy, yawning, craving foods, and sometimes then they can crave a particular food, have a headache, then think that it's the food that's giving them the headache, when actually we're beginning to understand that the migraine brain is behaving differently even before the migraine occurs, and so this might be part of the migraine attack itself. About a third of people with migraine then go on ahead to have an aura, and that's a very focal neurology symptom, and for many people it's visual, so they might describe zigzags or blurring over their vision or looking through water. Some people describe tingling on their face or their hand, and for some it's weakness. And that fully resolves, which is what makes it different from a stroke, and it is often followed by headache. But for many people, they just have they might have the aura and no headache after it. The headache you'll all be familiar with, usually a severe headache, but for some people that headache part itself isn't so severe, but there are very prominent light and sensation sensitivity. So for light, smell, sound, movement, you could feel that your head's actually sore whenever you move. And that can last from 4 hours to 3 days. And many people feel nauseated and just off their food. And then we move into the resolution stage, which is a gradual improvement in the headache. And the recovery or post-drome phase is a little bit like that premonitory phase. We just don't feel right, and it can almost feel like an undeserved hangover. So premonitory symptoms or triggers. What is chocolate? Is that something that is part of your premonitory symptoms? Bright lights. We know that the migraine brain likes balance. We know that many things impact on your likelihood of having migraine: sleep, exercise, other illnesses, stress, medications, caffeine, either missing meals and not being hydrated. And I'm going to focus in on sleep, exercise, stress, and medications in the next 15 minutes or so. Sleep. We all know that too little sleep is likely to make you have a migraine. That's not news, and it's not something you're going to learn here. But it's less well recognised, particularly, I suppose, by the non-migraine suffering population, that too much sleep can also give you a migraine. So that lie-in, that change in sleep whenever you go on holidays. And sleep itself is very closely tied in with migraine. One of the parts of the brain, the hypothalamus, that's involved with migraine is also involved with sleep. And that may be why when it is affected in the early or prodromal stage, why we feel tired or drowsy before sleep. And we also know that people with migraine will tend to wake in the early hours of the morning with migraine. So sleep's affected. What would my advice be on sleep? You could do a whole day on this, but my tips would be anchor your day with the same wake time every day. Try to avoid caffeine drinks for a few hours before bed, and that goes for alcohol too, as these affect sleep quality. The sleep experts talk about stimulus control. So that's looking at your bedroom or sleeping environment. They say that the optimum temperature of a bedroom for sleep would be 18 degrees. So it's cooler maybe than you might think. And also to try to only use your room for sleep-related activities and not to be using it for working or lying in your room during the day, scrolling on the phone or anything like that. Try not to nap in the day, and certainly if you're going to nap, don't do that in your bedroom if possible. And if you're really, really struggling with sleep, consider looking at CBT for insomnia. It's a non-drug approach to changing your sleep structure. One particular website is Sleepio that has advice on this, but you can look up CBT for insomnia. Exercise. It can be a bit of a contentious thing, can't it? Whenever you go to see your GP, there's always the advice that you people need to lose weight, they need to exercise frequently, and that is easier said than done. The reality is, for many people with migraine, the thought of exercising is too much because their head is sore. Exercising with a headache for most people doesn't work. But if you're somebody that gets plenty of time where you're not experiencing headache, then regular aerobic exercise can be beneficial. And I'm thinking of a paper that was written in 2011 comparing regular spin, which is cycling, with one of our best migraine prophylactic drugs, topiramate, and it was found to be beneficial for reducing the overall frequency and severity of headaches if this was built into the 12 weeks. But if you're trying to think about exercise for the first time, go at it slowly. Think about having a snack about an hour before, or making sure that you're well hydrated, and think about the type of exercise that would be suitable for you, whether that's walking or Pilates with a more deep relaxation involved. Stress. You can be unaware of the feeling of stress in the midst of it. And a bit like sleep, it's not just the stress that can cause the headache, but the relaxation from stress afterwards. I was speaking recently with an architect friend of mine who quite clearly identified that she wouldn't get her migraine when she was at the height of a tough project in her most stressful time, but she could pretty much guarantee when she had handed in, when the deal was done, when the stress was over, that there would be followed by a headache and almost a day in bed. And she thought, when she noticed the pattern, she decided to be proactive about it and build in deliberately times of rest. She said that she had noticed an improvement since she stopped trying to expect too much of herself after finishing a big project, not trying to fit in all the things that she didn't have time to do when she was working, but actually to build in that rest. So the point that I'm trying to make is that for that one person, it's looking at the trigger points of stress and being proactive about that. And how can you do that? You can take, I think a good way to do that is to keep a diary, looking at getting an objective idea of how many headaches you get a month, and how many medications you're taking, but also what's going on in your life around that time. And really you need to do that for about 3 or 4 months to get an overall picture. And it's when you reflect back on that you can probably see a little bit more clearly what's happening. So it's about not trying to battle the migraine itself necessarily, but acknowledging how the migraine, having the migraine affects you, working with the fact that you get migraine and taking active steps to mitigate its effects. So with stress, it's understanding your own patterns of migraine, work with how that migraine presents in your life. If you need extra help with this, is it possible for you to access cognitive behavioral therapy? And in particular, there's a type of CBT called ACT, called acceptance commitment therapy, which is very helpful for people who have chronic health conditions, in particular pain conditions. You don't have to go for this. You don't have to be depressed to go for this type of CBT or even anxious. It's just acknowledging the impact that it's had on your life. And really it is the principle of it is not letting the migraine control your life, but helping you to see the way that you can get the best out of your life whilst living with migraine. Thinking about relaxation, what are your ways to relax? Do you really relax? Are you the sort of person who says, I do relax, I go out for walks, but actually whenever you're going out for your walks, you're plugged in to listen to a podcast about work. You're texting people who you haven't got in touch with, you haven't had time to get in touch with. You're maybe scrolling and falling down a click hole, so to speak, on whichever social media platform you happen to like. But it may be that you need to learn some mindfulness techniques to truly relax whenever you're out for a walk or when you're doing those activities. Do you need to learn how to listen to the sounds that are around you? Appreciate the fact that you're out in fresh air. Appreciate the fact that you can do that relaxation technique. So it's something probably we all need to think about and practice. Medications. Now, medications for migraine. I think this is one of the cruel ironies for people who are affected by migraine, in that the medication that you actually take to relieve your migraine can worsen your headaches if you take it too much. And furthermore, when you present to your doctor with a daily headache, and it's noticed that you're taking your medications more than 10 days a month, that then it gets called medication overuse headache. And it's a term that I actually don't really like. I think that it seems to apportion blame when we know that this is not substance abuse. We know this is not drug addiction. We know that actually what's happening here is that people are using medications to help them to cope with poorly or difficult to control migraine, and that it's not a choice to go into this. And sometimes it's because they have not realized that this can actually happen, that if you take medications regularly, that it can change your 2 or 3 times a week headache to an everyday morning headache as soon as you get up that needs to have medication. The other sickening thing about it is that if you're given medication for another complaint, for example, a back complaint or a leg complaint, and you're taking that regularly, especially cocodamol, that can do the same thing. It can bring on a medication overuse headache in a patient with migraine. So it's pretty horrible. The good news is that, as we have been hearing this week through the scientific program, that there is benefit, real benefit, in a trial of completely withdrawing those medications. Now that's tough and it needs support with your GP. But for many people, they can go from having a daily, dull, difficult to treat headache to going back to having headaches that are every now and then and are much easier to treat and more responsive to the migraine prevention medications. So definitely worth having a think about that. These are rescue treatments. They can be simple painkillers like paracetamol, high-dose anti-inflammatories, for example, naproxen or ibuprofen, triptans, anti-sickness medications. And if you haven't tried an anti-sickness medication, I would encourage you to consider this with your GP, because it can actually augment the benefits of the other medication. And you tend to, what we recommend is taking the medications together at the start of the migraine. Avoid coding, really no place for it in migraine treatment at all. And remember that you do have a ration of about 8 days a month when it's okay for you to take rescue medication if you need it, which means that you might have a week where you don't need it, and then maybe a week where you need it 3 or 4 times. But just think about rationing your medication to avoid it. And then getting the best out of it, make sure that you have a plan. You know what you're going to take when you get your migraine, and you have it everywhere you go, so that you're not getting the tingling or the zigzags over your vision and running into a local chemist to look along the shelves to see what you can get. So know what your plan is, have it with you. If you're somebody who experiences aura, with the exception of triptan, all the other medications can be taken as early as possible in the aura, and you may not go on to have headache. But if you're somebody who does not experience aura, then I would say to take it as early as possible. What I do hear from a lot of people who are affected with migraine is they wait till it's bad. Don't like taking medications, so I'll wait. But if you wait until it's bad and your scalp is tender, then that is unlikely to work for you. There are 7 different triptans. They come in tablet form, a couple of them come in nasal spray if you feel sick, and one even comes in an injection if you're somebody that's vomiting. And this can be a great way of avoiding hospital admissions or home visits. If one doesn't work for you or agree with you, speak to your doctor about trying a different one. Preventative treatments. So you need to have, some people need to have preventative treatments along with taking acute treatments. You take them every day. They don't get rid of migraine attacks completely. They make them less frequent. They make them shorter and less severe. And they are borrowed from other conditions like heart conditions, depression, epilepsy. So there are lots of different migraine tablets that you can get from your GP. And if those don't work, then some people may be offered Botox through headache clinics or CGRP antagonists like ranumab, fremanezumab, etc. But the general principles are that whatever you're given by your GP, you start the medication at a low dose, and you then increase it with GP advice after a month. So speak to your GP after a month. Does it need to be increased? What increase would need to be made in another month? Do I need to be monitored? And when you get to the maximum dose that is tolerated, then stick with that dose for at least 6 weeks before looking, because it's going to take that length of time for the migraine brain to really calm down and for the headaches to settle. So persevere with it, stick with it. And if it does work and it works great for you, stick with that for a few months, and then you can consider reducing and coming off. But if it doesn't, go back and try a different one with their GP. At your GP consultation, I'm doing these telephone consultations all the time. I would say take a call in a quiet place without distractions, write down your questions and write down what the GP has to say to you. Talk to your GP about your other health conditions and medications to ensure your tablet's suitable for you. Are there any particular side effects you should be aware of? Do you need any monitoring? And if you're female, discuss contraceptive needs with your GP, as you should not get pregnant on any of the migraine preventatives. And in particular, topiramate and candesartan are particularly, you absolutely should not get pregnant on. And I'll leave you with this. If you need to seek professional help about your mental health, then do. It does take courage to live through suffering, and it takes honesty to observe it. And this is a quote from our East Belfast author, C.S. Lewis. So thank you for listening this afternoon.
Good afternoon. In the next 20 minutes, I'm going to do an overview of migraine with aura. I would like to deal with migraine with typical aura. The other types of migraine aura are brainstem, hemiplegic migraine, and retinal migraine. These are quite rare compared with the typical aura of migraine, which most of you know a lot about. Looking at the classification, you can see there are 2 subtypes of typical aura, one with headache and one without headache. Importantly, under section B, criteria 1, the typical aura should be fully reversible, visual and sensory, without other symptomology. Everyone should have a sense of what they personally feel or think about what migraine is. I think it's a sensory storm. It involves all modalities of sensation, but mainly vision and less so other visceral and somatic feelings. And it is importantly guided by the normal anatomical pathways of the brain. When it comes to pain, migraine, I feel, hijacks the pain system and anatomy to produce its symptoms. Other diseases can mimic this, such as tumors or strokes, for instance. So migraine also uses the normal anatomical pathways to produce the visual aura and other types of aura. We all know about the phases of migraine. About 30% of patients have aura prior to the headache, which usually takes us to the doctor. Other symptoms can occur before the aura, including premonitory phase symptoms, and afterwards in the poststrome. And even between attacks, people can have symptoms that are probably migrainous in nature. This particular graphic shows the phases of migraine. This shows that the premonitory symptoms can occur a day or two before the aura, and the aura, once occurring, then can blend into the headache phase. Migraine aura may not be preceded by a premonitory symptoms and may actually blend into the headache phase and overlap. In the third diagram here, we see the migraine aura in blue, where the premonitory symptoms overlap with the aura and the headache. More commonly, we see the graphic at the bottom where premonitory symptoms lead to headache symptoms. And finally, one can have aura alone without any headache whatsoever. I think what is clear from this diagram is that the aura in blue defines the migraine. It's a biological signature of a migraine attack. So I would say that it's important to understand the aura, to get the diagnosis correct, and for the person with the symptom and for the doctor, excuse me, analyzing the symptom, the aura is tantamount to making a diagnosis of migraine. Here is an interesting new book by Catherine Foxall, Migraine: A History, published by the Johns Hopkins University Press. It's very interesting in one way because it's the first open content text available. If you go to the Johns Hopkins University website, you can actually download this book in a PDF form free. You can also download separate chapters if you wish. I thought the cover of the book was most interesting. On the cover is a classical diagrammatic representation of migraine aura from Hubert Airy when he gave his presentation to the Royal Society of London in 1870. You can see the zigzag line, the so-called fortification spectra, and you can see it can be colored at times. On the right in her book, figure 6.3 shows the entire graphic that Hubert Airy demonstrated. Begins small, slowly enlarges over time, many minutes, in a C shape, an arc shape, and becomes an outline of a fortress. He called this a photograph, a picture, something that was invisible to others, but something that he saw during his migraine attacks before they occurred. This is important, and the shape of the architecture here may mimic anatomical shape in the back of the brain, in the occipital cortex. Types of aura are interesting. In looking at patients with migraine with aura, Russell and Olesen, in what is really a famous clinical article in Brain in 1996, looked at 163 patients with migraine with aura. Importantly, visual aura occurred in 99% of the attacks. Sensory aura, which I will discuss in a few minutes, occurred in 31%, speech abnormalities in 18%, and motor only in 6%. If one looked at a combination of aura symptoms in these patients, the visual symptoms alone occurred in 64%. Other symptoms alone occurred only in 1%. Combination of symptoms were 35%. As you can see, visual and sensory aura were very common in the combinations. I think this gives us a hint as to what is important in the typical aura. So here we have a picture on the right of aura, expanding fortification, a tachopsia, meaning a small town with optic involvement. Therefore, it looks like the outside of a fortress. It tends to be positive. It tends to have shape, color, light, movement, in contrast to negative symptoms as one would see in the warning of a stroke. It's often hemianopic. In other words, it occurs in half the visual field in the patient. This, of course, reflects the fact that the migraine is generated from the occipital lobe on one side and clinically represents itself on the opposite side of vision. It builds up and marches slowly, as we've seen in other diagrams, and it usually takes 20 to 30 minutes for the aura to complete itself. This can actually go up to 60 minutes in the ICHD3 classification, but generally the aura can be much shorter, and subsequent headache can follow in most patients. Here's a diagram, or a picture, I should say, of another type of aura, where the person has a scotomata, a loss of vision actually, inside the outer fortification spectra, or the scintillating scotomata, which in this case was generated by a computer and is colorful. So the typical aura can have visual loss as well as the other things that I've talked about up till now. How does this occur? Well, actually, the evolution of aura occurs over the cortex of the brain. In this diagram, you can see the side of the brain, and the bright red spot at the back of the brain in the occipital or visual cortex is the beginning of the aura spreading across like a wave towards the front of the brain. In the middle picture is the aura has gone to the level of the temporal lobe as well as into the parietal lobe. Eventually, it could reach the somocystic cortex and produce sensory or feeling symptoms on the opposite side of the body. If it moves a little bit further forward, it actually can produce motor symptomology. Lashley, an ophthalmologist, was the first one really to quantitate the aura duration. You can see here on the left side of the diagram that the aura expands over 5, 7, 9, 11, and 15 minutes. On the right, he shows the scintillations occurring over 3, 7, and 10 minutes. This was very useful, and actually the rate of progression of this aura was almost identical to what was called the cortical spreading depression of Leo. Leo, as most of you might know, is a Brazilian physician who, in an animal model, produced this electrical wave across the surface of the brain. It seemed to run at a certain rate, which is identical to the rate of aura. Therefore, many people started to associate the two. In this particular case at the Massachusetts General Hospital, this patient, who had a history of migraine with aura, was exercising outside of a functional MR machine set up in the hospital. He was playing basketball with his wife. When he started to develop symptoms, he was brought in and had functional MR done. This was done with the BOLD method, or the blood oxygen level dependent methodology. To make a long story short, the picture explains everything. You can actually see the beginning of the aura in the occipital lobe of the brain, moving forward into the other sensory areas of the brain over time with the change in the bold signal on the right. Just above the letter A, you can see the evolution of the arc-like aura occurring, and below you can see the anatomical representation of where it came in the brain. This particular diagram was created by blowing up a, quote, balloon, end quote, and then putting the images on the surface. This was very good evidence, given the speed of the propagation of the aura and the clinical correlation, that migraine with aura probably was related to the spreading depression of Leo mechanism. How these mechanisms trigger pain is still a matter of biological and clinical debate, but by far the sophistication of the imaging is telling us a little bit of how the brain works, how it explains itself, and particularly how it works in aura. There is another interesting case, again in Boston, published in the New England Journal of Medicine, when a patient was having a PET scan, a positron emission tomography scan. During the scan, the patient began to have headache. By recording again oxygen levels and blood flow, coloration of the areas of change were shown on the brain, particularly in red, mainly at the back of the brain and moving forward over time. This isn't a lot different than what we saw in our other pictures. Importantly, this patient didn't have aura. This might suggest then that the changes in the brain, the pathophysiological changes that occur with this wave, this sensory storm, as I would like to call it, can be present even in the absence of clinical symptomology. This would also suggest to me that migraine with aura and migraine without aura are not a lot different. I wouldn't expect them to be different, but some people feel this is a debatable subject. Let's look briefly at the sensory aura. Here is a picture from the Danish group of a man developing visual aura in his left eye. In the next 4 panels, you can see the evolution of the visual aura to the complete scintillating scotomata. You can also see that in the last panel, he's starting to develop numbness in the facial region, mainly in the lower face and also in the tongue. The numbness may not be complete loss of feeling, it may actually be paresthesia, a tingling, a positive phenomena, although numbness could occur over time. Importantly, again, you can see right from the beginning, he develops this tingling in his hand and thumb, begins to go up into his wrist, forearm, and arm. And with a complete evolution of the visual fortification, he has both. This is a case where a patient would have typical aura involving vision and sensory symptoms. Why is the anatomy of this important? Well, here's a picture of the anatomy of the brain. This shows 2 little men, could be women, I call them HALF or head, arm, and leg, on the surface of the brain as if you were looking at it from the front, halfway back. On the left is a sensory homunculus, the little man. You could see half his face, a large index finger, and a hand. The rest of the body is rather small. On the right, you can see the motor homunculus with a lot of representation for facial movements and also for thumb and hand movements. What's interesting is that this aura that spreads from the occipital lobe, or could alternatively begin in this area of the brain, produces symptomology by following the normal anatomy. So when the eye begins to have symptoms, the hand can begin to have symptoms because they're closely related. One interesting thing I always found about this classic diagram is that the sensory homunculus is looking forward in the brain to the motor homunculus, which is looking sideways. I always question and told the students, maybe the sensory system is looking at the motor system to see what it is doing. In fact, in neurology, we all know that the motor system is dependent completely, in many ways, on the sensory system to function properly. I think this is interesting and would require more research. Most textbooks have these diagrams done incorrectly. So if we look again at patients and say, why do some have aura and why some don't? We could look at what we could call a clinical expression threshold. Here you can see the spreading depression aura in A, B, and C by the solid line, And above it, you can see the symptomology expressed in each setting. In the first session, or the first section, the patient would have a low threshold, and therefore the migrainous aura would be expressed quite easily. Not so much in B, but still there, and in C, not at all. This again is important. I think again, it suggests that migraine with aura and without aura are clinically and probably anatomically and pathophysiologically similar disorders. In the end, I would like to talk a little bit about late life migraine accompaniments. This was a term coined by Dr. Miller Fisher in 1980. Dr. Miller Fisher is a Canadian who practiced at the Massachusetts General Hospital and one of the most famous neurologists in modern history for many things he described, including stroke, transient global amnesia, and other neurological disorders. He reported in the Canadian Journal of Neurological Sciences in 1980, 120 patients with transient neurological episodes resembling those of migraine aura. All had an onset after the age of 40, which he deemed the lower limit of midlife, and 20% had non-visual symptoms, but the majority were visual. Only 50% had headache. Some of it was mild, some of it was non-migraine type headache, but the majority of symptoms were visual. He developed rules for diagnosing this migraine aura. Importantly, this occurs in late life, and one would have to differentiate it from other causes of neurological symptomology, particularly vascular nature. So the visual symptoms were most common, as seen in the zigzag lines on the right. They build up and march over the brain, and they're stereotyped. In other words, the patient would have the same symptom each time. It could go to the right or left and be in the hemifield. The duration was 15 to 25 minutes, therefore close to the 30 minutes or 30% of patients having it. And some had headache and some did not. He talked about a midlife flurry. So if you had these beginning in your 50s or 60s, then one could easily get several in a row, and then they would gradually disappear and go away to come back again. They have a benign course over months, weeks, and years in most patients. Imaging of the brain, which is done because the patient and the person with the symptom and their doctor want to make sure there is no other causation. The normal CT scan and regular MR scan usually is quite normal. Migraine has as many presentations as there are brain structures. It's difficult for me to think of any part of the brain that migraine does not involve. Therefore, if there's anatomical areas that can express symptomology or brain function, migraine can find it. Neurological symptoms make it easy to diagnose. The presence of the classical visual aura is the neurological and biological signature of migraine. My feeling is that typical migraine visual and sensory aura deserve your special attention and study. If typical aura is present, then I believe you have migraine. I made a point at the bottom of the slide to say it's virtually pathognomonic of migraine. I can't really think of many other diseases or disorders that would even produce something equivalent to a classical typical aura. If it's not typical or atypical in any way, then I would look for something else. You might think that this will bring a lot of people to see their doctor. I don't think that's so bad. It's good for the doctor and good for the person to make sure they have the correct diagnosis. I believe understanding typical aura is better than fearing it. It will help you manage your life and migraine. I should have mentioned in the previous slide that on the picture on the right is my aura. I call it my photograph. This is what is invisible to others, but visible to me. It occurs on the right field or left field, and it lasts 19.3 minutes. I've been having them for over 20 years, and they haven't seemed to cause any problems. The doctors at one point did an image of my brain, an MR scan, for other reasons, and it didn't show any evidence to suggest this aura was related to another cause. Sometimes now I get a little nausea with it, and sometimes in the background I feel a little dull headache, but by and large, I've been able to survive with this fascinating neurological symptom. So here's my city, Halifax in Nova Scotia, Canada. This citadel that sits on the top of the hill was built in 1749 to defend the city against intruders. Interestingly, the citadel has an interesting shape, which we've seen throughout this presentation. It's a fortress. It's a zigzag. I think my city is a migraine city for sure. Thank you for your attention.
Great, thank you. Thank you for Louise and Allan for very interesting presentations. We have got a really great number of questions coming in. The way we're going to have to handle these questions is we've got a couple of speakers coming later who are specifically going to be talking about some of the issues which have been raised in the questions. So we'll drop those two later in the second session. So if you're wondering why we haven't managed to answer them all, that's why. And in fact, we do have an awful lot of questions, so we may not get through them all, but let's have a go at the first one. And this one, I think, will be for Louise. We're asked, I have migraines on an average 7 days a month. 90% of the time, they wake me between midnight and 6 a.m. The pain is general at first, and then mostly settles behind my left eye. Is this common? Do you have any advice for me?
Thanks for that question. Yes, it is common to wake with migraine. I think, as I mentioned, many people will wake at exactly the time that you've said. There are probably a number of reasons for that. That's sleep being connected in closely with migraine. I don't fully understand why you wake up early in the morning, but sometimes it can be related with stress, not possibly in your case, but people who get medication overuse headache, their headaches are more likely to be onset in the morning or more severe in the morning. And other patients report maybe having a buildup of neck pain, you know, in those days before and wake with morning headaches. Settling behind your left eye, it's really common. It's common for patients to have a one-sided headache, and they would, you know, that would be typical of classical migraine. Do I have any advice? The thing is just knowing what your migraine rescue plan is and having it available for those waking up. It's hard when the headache's already started, but getting the pain relief in early as you possibly can.
Thank you, Louise. Let's go on to this next one. I have between 15 and 20 migraines a month. I wake up with them and they last for 4 or 5 days, i.e. incessant. The pain is like someone drilling a hole above my left eyebrow. Can REM sleep be the cause? I think we all suffer from that one.
Yeah, so I know that's really tough for you. You're getting a lot of headaches there. It sounds like most of your month is taken up with headache days. I think really it's going to be a combination of those factors, and sleep being one of those factors. And I think I would say to go back to looking at prioritizing your sleep, maybe look at that CBT for insomnia. But the big question here is, are you on a preventative medication? And is it worth looking at the amount of days that you're having rescue medication? Is it worth maybe planning withdrawal of that rescue medication in conjunction with looking at your preventatives to try and calm that situation down of chronic headaches.
Mike, can I just editorialize on top of this that one of the things that's become that we've become to understand in terms of these relationships with sleep is the brain areas that we see using so-called functional imaging when we're looking at migraine attacks include regions of the brain that are intimately involved in sleep. In a structure that connects the spinal cord to the main part of the brain called the brain stem, there are regions that are active and alter their function during migraine, and they're involved in sleep. So the fact that the questioners are asking about the relationship with sleep is not unexpected. I think it's worth saying that as we begin to understand how this works over the years, we'll get better answers to the questions that you're asking. So it's not like anyone's crazy with this. It's a real thing, and there's a real biology behind it.
Thank you.
So let's go to Allan, shall we, Mike?
Yeah, let's go. I've got one for Allan.
Allan,
I agree with a sensory storm, but with silent migraine and no visual changes, what treatment can actually be offered?
Well, it depends on what you mean by silent migraine. If you mean visual symptoms without headache, then that is a separate disorder that I discussed. Frequently, they're called late life migraine accompaniments. They don't necessarily mean they come when we're 50, 60, or 70. They could begin when you're 40. If you began to have migraine as a teenager, then late life for you might actually be around 40 or 50, or midlife, as I should say. There are no really effective treatments for that. No clinical trial data that show anything that takes it away. People have tried various things over time. They've tried things like riboflavin. Some people have tried a little aspirin here or there. But again, that's very personalized, idiosyncratic, and I don't necessarily think it makes any difference, partly because I don't think it changed the biology of the visual symptomology if it was a silent migraine. But my approach to that is to make sure that's exactly what the diagnosis is, and there is no alternative diagnosis that could be offered.
Thank you. And can you hear music that's not there with aura?
It's possible, I suppose. There are people have reported hearing music. I've never seen a patient that had that. You see it with epilepsy once in a while when music triggers a seizure, a particular singer, a country or Western, rock and roll or opera, but I've not seen it with migraine. But I would not be at all surprised if someone came in and described musicogenic or music related migraine aura. I probably would think that's a little bit atypical and probably want to look into it a bit more to make sure there's nothing wrong with the temporal lobe or another part of the brain where music is generated near or around the auditory cortex. Also, of course, music could be a memory. Also, music for some people tends to help them when they're having a pain, but for most people with migraine, music would probably be a no-no. They wouldn't really want to hear sound because they have phonophobia. But it's a very, very interesting question. And if it's a persistent, unique problem for a patient or two, then I think I would take that up with your primary care physician and or your neurologist to ensure that this is the case. It may actually be a reportable case if it could be documented.
Interesting.
Louise, maybe there's a couple of questions around general guidance on pain relief. Offer a guidance on pain relief. Someone who's worried about rebound headaches, and other person asking about pain relief more broadly. So some broad guidance around pain relief in migraine.
Yeah, so I think broadly, knowing that your acute relief, it won't work every single time, but you do want to have your painkillers, your pain relief ready early, ready to take. So it does mean that you need to have some of it wherever you are, like at your work, in your bag, etc. So the headache's not building up. I think what's important to know is triptans. They're specifically migraine acute pain relief, and they're very underprescribed. So if that's something that you haven't tried, it's certainly worth going and talking with your GP about that. Triptans work really well for migraine, but some of the there have been studies to say that some of the anti-inflammatories, when they are given together with the triptan and early, that they can work very well together. So I think it is a matter of getting, trying over 2, 3, 4 migraine attacks to see what works for you. So it might be triptan plus an anti-inflammatory, or it might even be triptan plus an anti-inflammatory plus an anti-sickness medication, and taking those early.
I think you must have had the experience of if one triptan doesn't work, another one might, which is a little frustrating because they're all serotonin 1B, 1D receptor agonists. But I think that 20 years of experience have taught us that failure with one doesn't necessarily mean failure with two. With it, is it a fair comment? Yeah,
and also some of them work quicker than others. So we might have had patients who say, well, that works really well for me, but I always get, a rebound headache later in the day. And then I've tried them on a different triptan, like frovatriptan or naratriptan, and they say, well, that actually works very well for me. That gets rid of my headache and keeps it away. So that, that's beneficial. And remembering that there are the options of trying the nasal spray in 2 of them, or the melt in the rizatriptan. And you might have to push a little bit with that, because sometimes it's, that's not appreciated by all doctors, all GPs, my GP colleagues, and I've done a lot of education about this with our colleagues. So it might be on you to go and push with that and say, I'd really like to try a different one. I've tried that one and it hasn't worked.
It's difficult for GPs. They've got, there's 1,000 conditions in the book, and the medical textbooks at 3,000 pages. And while migraine's common, there's I mean, that in general practice, in secondary care, we've got the luxury of just sort of focusing on one thing. In primary care, you don't know what's going to walk in the door next. And I think a good partnership of asking and interacting with GPs.
Oh, absolutely. And I am a GP, so
yes.
I appreciate that, and I also know that it's helpful if a patient has, we have this concept of expert patients, and if you've gone and read about something, don't be afraid to bring it to your GP. We want to hear about your questions or something that you've read, and we'll look at it usually. But that's what I would say about triptans.
And just while we're talking we'll just get one other little one that people ask about all the time, I think, often. How do I avoid getting migraine during dull and cloudy weather? It's a major trigger for me. Weather and migraine.
Yeah, you might be the best person to answer that one.
I often think, I often suggest people move to Spain or something like that. It's difficult, isn't it? The weather thing. It's funny that when it's been studied, it's really tricky to get clear information about this. I mean, I think the bottom line is you can't avoid the weather, and I think it loops back to what you're saying, that when you feel an attack coming on, you need to treat early. You need to treat early when the pain is still mild to get a better result, and you need to be prepared. There's no point. If you've got migraine and your cupboard is empty, then that's not really going to help anybody. You need a strategy, and then you need a rescue strategy as well. So I think preparation is an important thing. And then, of course, the other thing, I don't know how you think about this, but there's prevention. Eventually, if you're getting too many attacks, you can't change the weather and you can't change the world. Perhaps you need to think about prevention.
Yeah, I mean, I like to think... Sorry,
I used to tell the patients, when the pressure goes low, lay low. You know what's going to come. The storm is about to occur. And we have the Chinook in North America. You have the Sirocco, North Africa, et cetera, et cetera. And the theories behind the relationship sort of get a little bizarre, but there's something to it. Patients continually tell us a weather change. So I think low pressure systems might be the more of a concern. So if you lay low and be prepared, it might actually help.
I think so. I live in Northern Ireland, where there are plenty of dull and cloudy days. But I like to think about the migraine threshold as such that people have. So, so it may be that things are going well for you. Your migraine attacks are very well under control, and there is a dull, cloudy day, and you don't get a migraine attack. But at another time when there are a buildup of other factors, including, stress or lack of sleep, or just, other things that might be feeding in towards that, and your threshold for having a migraine is lower to begin with, then that's when that dull and cloudy day might make you more likely to have the migraine attack. So it's not just going to be that very one thing. It's usually, a combination of things. But I think if the weather is frequently impacting, then again, thinking about migraine prevention medication to try and help you to sort of raise that threshold for having the migraine attack and calm the brain down.
I have a question here, which is about aura. I get black dots and spidery lines as my aura rather than the zigzags and patterns other people experience. Could it be retinal migraine?
It's unlikely to be retinal because if it involves both eyes, it's more likely coming from the cortex per se. And the retinal migraine is more of a negative event without signs or symptoms other than the loss of vision in one eye. But spidery cobwebs aren't exactly out of the description of the zigzag lines. They still have that angulation to them and other things like that. And some black dots are not at all uncommon. I would think that if this was a consistent and persistent aura over time prior to a migraine, the likelihood is you have a slight variation on what I've described in my talk. I don't think it necessarily excludes a typical migraine aura in any way, but again, it's something you should probably, some say, draw it out, draw a picture of it. There are other secondary lesions of the brain that can present with migraine aura-like signs and symptoms, but again, the spidery web phenomenon is something that wouldn't particularly bother me if it was a long-term thing. If it was something new, I think, again, one would be advised to tell her GP about this and or talk to the neurologist. I think neurologists would find this most interesting, and you would as well. But again, I'm not going to exclude it, but I doubt it's one eye. And if it's present in both eyes, in other words, it's half of each visual field, you close one eye or another, and you can see that on your retina like a black screen. The likelihood is coming from the cortex. The likelihood it's migrainous in origin, but one would have to be just a little bit careful about changes from typical or classical aura.
We're getting a few questions now about medicines in specifically. There's a medicine called Midrid that's been discontinued. Do we have any suggestion for any equivalent substitutes?
So Midrid, we just had a look about that, and that's a paracetamol with an anti-sickness medication. So the other option is to get your GP to prescribe an anti-sickness medication and take both. So that's one thing. And there is a combination medication called Paramax, which is paracetamol and metoclopramide, that is available on prescription. But again, the use of that needs to be low numbers per month, and you would need it would be on prescription, and you'd be counselled about that through your GP. But there are a number of anti-sickness medications that can be prescribed. So taking them along with the paracetamol or the anti-inflammatory or the triptan. So I don't know if that helps with the combination. There are not that many combination therapies available that way.
I have a question here about heart attacks, and somebody's had a heart attack this summer and wants to know if that prevents them from taking Amivov. drug, one of the new CGRPs, isn't it? I'm not sure.
Yes, the same. I think they're asking about Aimovig and heart attacks. And I think David Dodick will probably cover the CGRPs in a little while, and we could come back to that one. Short answer is if you've had a heart attack, then caution is the first 3 words that come to my mind 3 times.
Can I get a rebound headache using topical Nurofen?
So topical preparations, the amount of that goes into your system is probably very low. I haven't seen anybody with rebound headache from topical Nurofen. The other thing to say though is that are there other things that are being used? So quite often people maybe don't realize that simple paracetamol can give the rebound headache. So if somebody's using tablets that are paracetamol and topical Nurofen, I think it's more likely to be the paracetamol that's causing it in that case. Have you ever seen that, Peter, about the topical? I haven't.
I haven't seen headache problems develop with topical anything, particularly topical non-steroidals and specifically ibuprofen. No, I haven't. That would be a bit unusual thing. Must have to do with absorption, I suppose, because there's, it's in principle the same medicine. And I'm a little agnostic about non-steroidals and medication overuse problems as it is. I don't think the data is as clear as it is for triptans or for codeine, opioids, codeine-based products. Of course, in the UK are available relatively more easily. For triptans, it's pretty good. So that it's messier for non-steroidals, I think, from a data perspective.
Patient saying here, I have a numbness in my face, arms and legs. Why? I have a clear MRI and, of the spine and brain. So he's had an MRI done of the spine and brain, which are described as clear, with some numbness in arms and legs. Is that anything to do with our migraine?
It's possible. It's a bit unlikely if it's bilateral, because most of the sensory aura, as I described in my talk, is on one side. It's unilateral. And it has a particularly spread that spreads both from the hand, the fingers, up the arm, and then into the face region because of the close anatomy of those in the picture I showed of the section of the brain. But to have this bilaterally could raise the possibility of somebody with so-called brainstem aura, what used to be called vertebral basilar migraine. But again, if it's absolute numbness or loss of feeling, that's a bit more of a concern if it's paresthesia. So I think another problem is if you involve the tongue, it tends to be more migrainous in nature, but if the tongue's not involved in bilateral, then there could be other possibilities in vascular disease. So I think that's, it's possible, but again, that's not typical. And therefore I would again have to suggest that be looked into just a little bit more through a more detailed history with your GP or neurologist.
Okay, we're doing really well on the questions. We've got a couple of minutes left. We probably can squeeze maybe one, maybe 2 more. There's one here about if you're a migraine sufferer, does it make you more vulnerable to having a stroke?
I would say migraine with aura is a risk factor for stroke, particularly in younger women, more likely who are on estrogen-containing compounds. I suspect we'll hear more about that later in the day with the talk on estrogen and migraine. Yes, that's always a possibility. There is experimental evidence about how the spreading depression can produce microischemic-like events in animal models. But by and large, there usually are other risk factors for stroke. But yes, there's no question if you have migraine with aura and you're young and you're on an estrogen-containing compound, and particularly if you smoke, then the risks actually increase quite significantly. I mean, there's still less than 10% cumulatively, but it's not zero. So these are factors you have to look at very carefully and try to avoid those situations if possible.
Okay.
We might take one little short one for, well, short. Louise, nausea with migraine is sudden and severe, struggle to keep medications down. What do you advise people who have nausea problems and you've got no pressure, but you've got 50 seconds?
To think about the nasal spray of the triptan, and to think about dissolvable forms of the other medications. So in the case of aspirin, the dispersible. And some people who get very significant nausea and vomiting benefit from the injectable. So it's a sumatriptan that you inject yourself with. And then when that nausea settles, you can add in the other medications. Sometimes you can't even get the anti-sickness in, but getting the triptan in another form is important.
Fantastic. Well done. Well done.
Well done.
Okay, thank you. Big thank you to Dr. Rusk and Professor Purdy for their excellent contributions. Thank you for that.
Thanks, team.
See you soon.
We shall return.
Great.
Hello, my name is Shazia Afridi. I'm a consultant neurologist in London, and I'm going to talk to you today about migraine in women. These are my disclosures. I'm going to cover some practical issues with you today. I'm going to talk about migraine around the menstrual period. I'm going to talk about contraception and the issues around that with migraine and how you can manage your migraine in pregnancy and what happens in the menopause. So I'm going to start with this picture, which is taken from a book from the 19th century, a French book actually, and it shows that it's been known for a while that women have migraine and probably more than men, and I think they knew this back then. And it depicts some images of some features of migraine quite nicely. So you can see this woman has multiple servants. One of them's tiptoeing around so as not to make too much noise. There's another maid trying to stop the child from banging the drums. I think we all need some of that. I like that to help us with our kids sometimes. The woman may have vomited and someone's removing the vomitus from the bedpan. So we know that women are 3 times more affected and more commonly affected than men. And this change occurs after puberty. So before puberty, girls and boys are equally affected. And so the reason for this is hormonal. And the main hormone that's involved is estrogen. And estrogen fluctuates at different times in a woman's life. And this diagram shows you that at different points in a woman's life, migraine can affect her more. So the first time is usually around menstrual period. So just before the menstrual period, women can often have a migraine triggered at that point. Women who have been pregnant after they give birth can often have a flare-up of their migraine, and there's often what we call a perimenopausal flare-up. So around the time of the menopause, women can also have migraines quite badly, and these are all due to the fluctuations of levels of estrogen. So starting with menstrual migraine, so this is migraine that occurs just before or around the time of the menstrual period, and it's very common, affecting about 50% of women with migraine. And this diagram shows you the 2 hormones that are involved in the menstrual cycle in women, and that's estrogen and progesterone. And estrogen here is marked in blue. And what you can see is that both of those hormones go up and then they suddenly drop just before the menstrual period. And some studies were done back, I think, in the 1970s, trying to work out whether it was the drop in the estrogen or the drop in progesterone that would trigger the migraine. And the way they did this is they got some women with the menstrual migraine and they gave some of them progesterone and they gave some of them estrogen supplements. And they worked out that giving the progesterone made no difference, but the ones that had an estrogen supplement, they could sometimes abort or delay their migraine. So it's the drop in estrogen that's important. We know that migraine that occurs around the time of the menstrual period is often more severe and less responsive to the normal medications than it is other times of the month. And it can start 2 days before the onset of the menstrual period and can carry on throughout. What can you do about it? Well, it depends on whether the woman has regular periods or irregular periods, because if they're regular, you can plan certain treatments to start 2 days before. And what you can do is give a group of drugs called non-steroidal anti-inflammatory drugs. So that's the group that includes things like ibuprofen, but you can use something called naproxen, which some of you may have already been on for migraine. You can take, instead of taking it just when you have a migraine, you take it 2 days before you expect your period, and you take it twice a day, and you can take it for up to a week to cover you for that period of time where you're more susceptible to having a migraine. And you can do the same with triptans, which again are a group of drugs that many of you may be familiar with, but you can use a longer acting triptan. So in this case, you'd use probotriptan. If you have an irregular menstrual cycle, then you have to use more hormonal mechanisms and methods. So you can do, you can take the combined oral contraceptive pill back to back. So if you're already taking the combined pill, that's the pill that contains estrogen and progesterone. So that's designed to usually be taken for 3 weeks and then have a week off so that you have a period. But what you can do is take that back to back for 3 months. So instead of having a period every month with a migraine, you have a period every 3 months with a migraine. And similarly, you can also shorten that pill-free period from 7 days to 4 days. Other things that can be used are estrogen supplements, much in the way that they used when they were trying to determine what was the cause of migraine in menstruation. And so you can take a supplement of a gel or a patch, again, starting before that period. Other methods are using depo-progesterone to try and stop the periods coming in the first place. And some women also find taking the progesterone pill Cerazette can be helpful. So now I'm going to talk a bit about contraception in migraine. And I guess there are two issues here. One question that I'm asked is, what will happen to my migraine if I'm on this type of pill, for example? So firstly, looking at the combined contraceptive pill, which is the one that contains estrogen and progesterone, we can't really predict the response there. It's quite variable. So some women get better, some will get worse, and some will stay the same. There's no clear effect of taking the mini pill, which is a progesterone-only one, but there is some studies suggesting that some people who take desogestrel, which is Cerazette, can notice some improvements in their migraine. And if that is the case, you can then consider a more longer-acting progesterone drug, such as like the implants or the injections. So the second question is it safe? And the question relates to risk of stroke, because there were some studies suggesting that women who have migraine with aura have a slightly increased risk of stroke than other women. Probably not like to be affected if you just have migraine without the aura, which is what most migrainists have. And also, women with migraine with aura who are on the estrogen-containing contraceptive pill is thought to slightly increase the risk of stroke further. So that's the issue of safety. And because of that, the recommendations now are that if you have migraine with aura, you should try a non-estrogen-containing contraceptive rather than an estrogen-containing one. There's no suggestion of any increased risk of stroke with any of the progesterone only contraceptive. So that's the progesterone pill or the implant or the depot injection or the coil. So if you think about the risk of stroke in women, it's related to age as it is in male as well. But so the risk is actually quite low. If you're a young woman who have no other risk factors, you're not a smoker, because obviously smoking increases your risk of stroke. Then, you know, if you're a young woman in your 20s, it's about 2 in 100,000. That's quite low. So even if you double that risk, that's 4 in 100,000, which is still quite low. So it's a slight increase if you think about the absolute risk overall. And the risk relates to the estrogen-containing contraceptive pills, and it actually relates to the estrogen dose. So the studies that showed us that there's an increased risk of stroke in women with the pill who have migraine aura were all done using, well, most of them were done using the older pills, which had a much higher level of estrogen in them, about 50 micrograms. Nowadays, most of these pills contain 20 to 30 micrograms. And as you can see here, the risk, this OR business means the risk of stroke, is higher if you're on a higher dose of estrogen and much lower if you're on the lower doses. So what we don't have, unfortunately, is good data to tell us what the risk of stroke is in women with migraine taking the current estrogen-containing pills. And we don't have that data, sadly. So the next slide here just shows you that some drugs that you may be taking for your migraine can interact with the contraceptive pill. And one of these drugs is topiramate, which is a migraine preventative that many people take. And so if you are taking topiramate, you should be on adequate contraception, because it can cause increased risk of birth defect if you're pregnant on it. And the ones that are safe to use are the depot injection of progesterone, which is the one that you get injected every 2 or 3 months, or the coils. And if you're on any other method of contraception, you have to take extra precautions. So you might need to use barrier methods, for example, or speak to your GP about that. So moving on to pregnancy. So the good news is that most women find that their migraine improves by the end of their pregnancy. It might be a bit rocky in the first trimester, but most women get better by the end of the second and third trimesters. And that's because your estrogen levels go up. And then again, in this little chart here, you can see estrogens in dark blue. Some women have a migraine aura for the first time during their pregnancy, and that's to do with estrogen as well. And it's nothing to be worried about. Unfortunately, after the baby's born, about 3 days afterwards, there's often an exacerbation of migraine, and that's due to the sudden drop of estrogen, but it's also due to other factors. Clearly a very stressful period, maybe a lot of sleep, well, definitely a lot of sleep disturbance, certainly in my experience, and you're not meeting your meals regularly. So all of these things are typical migraine triggers, lack of sleep, missing meal stress, in combination with the drop of hormones. And that's why things can be a bit rocky in the postpartum period. What can you take during pregnancy? Well, paracetamol is thought to be pretty safe, but of course doesn't work for everybody. Ibuprofen and naproxen can be taken, but only until the 32nd week of pregnancy. After that, it's not safe to take. And some people don't like giving it in the first trimester either. Triptan drugs, so Migraine, sumatriptan, and some of the other triptans can be given. I'll show you a slide on that in a minute. And then you can take anti-sickness medications like metoclopramide. Some headache centers can organize something called a greater occipital nerve block during pregnancy. So that can sometimes give you a bit of a break as well if you're having a flare-up during the pregnancy. So triptans. So these are drugs like Migraine, amitriptan, Zomig. These are all triptan family of drugs. And the reason I got a picture of Greta and a cat here is because Greta represents the Swedes and this Norwegian forest cat represents the Norwegians, because they produce the most data here, looking at over 4,000 women who've been using triptans during pregnancy. And it's allowed us to then follow up and see what happened during their pregnancies and did it have any effect. And the good news is that it wasn't associated with any birth defects and also not associated significantly with any miscarriages. So that's good news. So just to summarize, what can you take? You can take paracetamol, you can take naproxen, ibuprofen, sumatriptan, and then preventatives. Well, no preventative is 100% safe during pregnancy. But if you have to be on a preventative, then propranolol, so the beta blocker drugs, or amitriptyline are the least riskiest, the safest options. You can also have a greater occipital nerve block. You can have acupuncture. That's safe. And then some women have used magnesium as a preventative and can try using that as well. There is some data which hasn't been published yet, looking at whether Botox is safe. At the moment, it's not recommended, but there's a paper looking at a group of 45 women. I think one of them had a miscarriage, so we'll have to see what happens there, but at the moment, it's not recommended. Riboflavin is a vitamin that some women have used, so some people in migraine have used, not just women. And at normal doses it's safe, but the doses used in migraine, we're not sure whether they're safe in pregnancy. And also coenzyme Q has been used after 20 weeks. But again, data on these other less commonly used drugs is not as well available as data on the other more established drugs. What about breastfeeding? Well, some of these drugs can transfer into the milk, and the safety relates to the amount of drug that transfers. So if it's less than 10%, then that's better. Also, it relates to the age of the infant. So premature babies are much more susceptible to these drugs. Once they hit 6 months, their metabolism is quite good, and so they're much less susceptible. So you can go back to taking things like ibuprofen if you'd had to stop it at the 32-week point. And paracetamol, you can take triptans. Usually the tablet forms are less likely to transfer into milk than the injectable forms. Domperidone is an anti-sickness tablet, which can often be given, in fact, helps lactation, helps breastfeeding sometimes. And then with the preventatives, again, beta blockers like propranolol, amitriptyline. Some of the drugs that used, like candesartan, which you wouldn't use in pregnancy, you could go back on to unless your child is premature. And then some of the others you again can go back on to, just be a bit sort of wary of sedation effects and things, and make sure that you're on contraception because you wouldn't want to get pregnant on something like valproate. You wouldn't want to get pregnant on topiramate. Finally, getting on to the menopause. I often see women in their 40s coming to my clinic who'd had their migraines been pretty well controlled for a long time, and then suddenly getting this flare up. And that's quite commonly due to the fluctuations of estrogen that happen around the time of the menopause. So the good news, however, is that about 2/3 of women will improve once they get through that rocky perimenopausal period, and things will then settle down. You can treat migraine, perimenopausal migraine the same way you treat any other migraine with the same medications. But if you have other menopausal type symptoms, then you can think about HRT, hormone replacement therapy. And in some cases it can make migraine better, some cases it can make migraine worse. So again, it's one of those things that's difficult to predict. What I do recommend is, if you are going to go on to HRT, that you use the patch, a transdermal patch, rather than the tablet formations, because firstly, that gives you a more consistent level of estrogen, so that's less fluctuations, and that's better for migraine. And secondly, it's also safer, so there's no increased risk of stroke with the transdermal patch. So that's a safer method of using for HRT. If you haven't had a hysterectomy and you still have a uterus, then you'll also need to go on to a progesterone-containing tablet or coil as well while you're on the estrogen. And some women don't want to go on HRT, I don't like HRT, and still have menopausal symptoms, and then you can try some other medications, some vaccine, citalopram, clonidine. They may also have some effect on the migraine too. So to summarize, it's quite clear that migraine varies at different points in a woman's life. In an ideal world, we treat everyone on an individual basis, looking at their individual risk factors. And in order to do that, we need better data. Thank you very much.
Hi, everyone. My name is David Dodick. I'm a professor of neurology at the Mayo Clinic, and I'm delighted to be speaking with you today on new therapies. What can patients expect? I want to thank Professor Goadsby and the organizing committee of the Migraine Trust for giving me this opportunity to speak with you today. The past 2 years has been remarkable for patients with migraine, given that we have had 7 new drugs approved, at least here in the United States, for the treatment of migraine. And in my over 25 years of taking care of patients with migraine, never has that been the case. So it's really been an unprecedented time for us as doctors, and most importantly for patients. So I'm going to talk today about these 7 new drugs and what you can expect from them. This is my disclosure statement. So I've advised the companies who have designed and developed and manufactured these therapies, specifically with regard to clinical trial design and the interpretation and analysis, and sometimes the publication of the results. Just to get the vocabulary down, the 3 different drugs that I'm going to talk about today are anti-CGRP monoclonal antibodies, otherwise known as MABs, CGRP receptor antagonists. These are drugs and not antibodies, and these are known as GPANTs. You'll often hear them referred to as that, and serotonin 1F receptor agonists. I'll talk a little bit about what that means, but these are referred to as DITANs, and there's one available now. So just to get the vocabulary down, because you'll be hearing about MABs and GPANTs and DITANs, and you'll read about them as well. So what's different about these new therapies? Well, they're disease specific, and they're based on mechanisms that are important in migraine. That's what's different. Let's first set the table here in terms of what's different between acute drugs and preventive drugs, because the drugs that have been approved, some have been approved for the acute treatment and some have been approved for prevention. So acute drugs can be thought of as on demand or as needed. They're intended to relieve symptoms after the attack has already started, to relieve the pain and to relieve the other associated symptoms. Preventive treatments, in this case both biologics or antibodies, as well as drugs, are taken on a scheduled or a maintenance basis, and they're intended to prevent attacks from starting in the first place. These have been developed specifically for migraine. So in contrast to the drugs that have historically been used to prevent migraine especially, they were developed for high blood pressure or depression or epilepsy, and are now used for the prevention of migraine. These drugs were developed specifically for migraine. And they were developed specifically for migraine because we now know enough about the biology of migraine to start designing drugs that target specific proteins or receptors. And in this case, a number of different antibodies and drugs have been developed that target something called CGRP, or calcitonin gene-related peptide, or its receptor. And you can see this little cartoon on the right-hand side of the slide there, where you have a receptor that's embedded in the membrane in the cell surface, the membrane of a cell. And a protein comes and attaches. It could be a drug that comes and attaches to that receptor and either blocks the receptor or indeed may excite the receptor. Whatever it does to the receptor, that has consequences for the activity of the cell and for its ability to release certain proteins and other chemicals and neurotransmitters. So these new drugs target either CGRP or its receptor, or it targets the serotonin receptor. And I'll talk a little bit about that in just a moment. Unlike the only other migraine-specific drug out there that's generally used most often, which are triptans, these new drugs do not constrict blood vessels. It used to be thought that migraine was a problem with the dilation or the distension of blood vessels. And so the target has always been the blood vessel, to constrict it and therefore relieve the pain. It so happens that you don't need to constrict the blood vessel, and in fact, migraine is not thought to be due to dilation or distension of blood vessels anymore. So these new drugs target peripheral nerves that are outside the brain, or indeed centers in the brain itself. So no longer do we need to constrict blood vessels, which is really important, especially for people who have heart disease, stroke, or other cardiovascular risk factors. So this is a cartoon. It's rather complex, but you can see that in the center of this picture, there's something called TG inside of a little circle. This is the trigeminal ganglion. And so the trigeminal nerve comes out of the brainstem, goes through the trigeminal ganglion, and at least one division of the trigeminal nerve supplies, innervates, or embeds itself into pain-sensitive structures inside the head, particularly the capsule over the brain, or what's called the dura, or blood vessels. So those are pain sensitive, and these nerve fibers are embedded. And when these nerve fibers are activated, they release their contents. And one of the particular components is calcitonin gene-related peptide, or CGRP, that is released. There's another protein which we'll talk about in a moment called PACAP38, which is going to be another target for migraine in the very near future. But CGRP is released during a migraine attack, and when you give CGRP intravenously to a patient with migraine, it will inevitably precipitate an attack in most of those people. And when you give effective treatments to people, the elevated levels of CGRP decline. So we've known for over 30 years that CGRP is important in the biology and in the mechanism of generating and maintaining a migraine attack. You can see that when these nerve fibers come back into the brainstem, they go up and register in the cortex of the brain that you have head pain. So this is kind of the anatomy of headache, but it emphasizes the role of CGRP, and in particular PACAP, as important neuropeptides in the biology of migraine. So there have been 4 monoclonal antibodies that have been developed that target either the CGRP protein itself or its receptor. And these are all approved in the United States and in many countries around the world. There are 3 that are given subcutaneously in the skin once a month, and there is 1 that's given every 3 months, that's given intravenously. Now, these biologics or antibodies are proteins, so they're broken down in the body like other proteins are, and they're not metabolized by the liver, not excreted in the kidneys, so they don't interact with other drugs, which is a bonus and a benefit. They also have a long half-life. In other words, it takes about a month for half of the drug after it's administered to get out of the body, and then another month for that remaining drug to be cut in half, and so on and so forth. So because it takes about 5 half-lives to get rid of a drug out of the body, if the half-life is a month, then it takes about 5 months or so to get the entire drug out of the body. Now, the advantage of a long half-life is that it doesn't have to be administered that often. So unlike tablets or drugs, it doesn't have to be taken every day. It can be taken once a month or even once every 3 months. The disadvantage is that if there are side effects, or if a young woman is thinking about conceiving and getting pregnant, then the drug really has to be out of the system before doing so. So sometimes the long half-life can be a bit of a limitation. So these are the 4 antibodies. And in a moment, I'll talk about the CGRP receptor antagonists, or the GPANs, which are drugs and not antibodies. So when we talk about what patients can expect, there are 2 situations that we look at to determine what patients can expect. One is the control setting, where we do these clinical trials and expose patients either to the drug or to placebo. And then what happens in the real world when the drugs are approved and we start using them in patients in our clinical practice. So let's take a look at what we learned so far from the controlled clinical trials. Essentially, the way we determine success in a clinical trial is we look at the proportion of people in the trial who have a greater than 50% reduction in migraine days on a given month. And for people with episodic migraine who have less than 15 headache days per month, we see that the proportion of patients who have a greater than 50% response varies between 43 and 62%, but roughly about half of the patients have a greater than 50% reduction. And in about a third of patients, 31 to 39%, they have a greater than 75% reduction in the number of migraine days per month. If you look at chronic migraine, these are people who have more than 15 headache days per month. They can have headache every day, actually. The numbers are a little bit lower, maybe 28 to 55% is the range, but roughly 35 to 40% will have a greater than 50% reduction in the number of migraine days in those who have chronic migraine, which is oftentimes a little more challenging to treat. From a side effect standpoint, the overall number of side effects and the serious side effects that occurred, there was no real difference between any of the antibodies and placebo. In terms of side effects that led a patient to discontinue or withdraw from a clinical trial, that occurred in about 2.5% with the active treatment or the antibodies. And there was no difference when compared to placebo. So a relatively favorable side effect profile. There is a caution, though, when these drugs were approved, when these antibodies were approved, that patients could have a hypersensitivity, allergic, or an immune reaction, because unlike drugs, you can actually develop antibodies to the antibody because the body sometimes sees it as foreign. And some foreign And sometimes these hypersensitivity reactions can be anaphylactic, can be quite severe. Sometimes we see injection site reactions with a little swelling or redness or a little rash around the injection site. And for one of the antibodies, constipation occurred in about 1 to 3%. So that was the side effect. So that's what clinicians and patients could expect from the clinical trials. So what's actually happened in the real world? Well, in the real world, I think what patients can expect is similar effectiveness as we saw in the trials. And that includes even in patients who have failed multiple other preventive treatments. For example, our patients have generally failed somewhere around 10 preventive treatments before they get to us. It occurs even in patients who use a lot of acute medicines, so they may be taking these on-demand medications more than 10 days per month. And it can even occur in patients who wouldn't have been otherwise eligible to get into the clinical trials because they had some other disease that made them ineligible, like a chronic pain syndrome, for example, apart from headache. We've seen now that the onset can be as fast as a day, particularly with the intravenous antibody, but the subcutaneous antibodies can work within days to a week. And that's a lot faster than typically we see with oral preventive medications, which generally are titrated in dosage over the course of 4 weeks or so. And then we usually allow for 2 to 3 months to see if there's an effect. In addition to a reduction in the frequency of migraine days, we will sometimes see a reduction in severity and in the duration of the attacks, which is terrific. And they can be used safely and effectively with other preventive treatments because, again, they don't interact with other drugs because they're not metabolized in the liver. They're broken down like other proteins are. And so that's definitely a benefit. It seems that patients may switch successfully to another antibody if the one that they're on isn't effective or well tolerated, because there does appear to be a difference in the way people respond to these, in the way any one individual responds to the different antibodies, both in terms of effectiveness and in terms of side effects. We think that's the case. Time will tell as to whether that's truly the case. And effectiveness can increase over time. And that's clear with all preventive treatments if patients can stay on them. So here's an example of a study that was done with arenumab, which was the first antibody approved. And these are patients that actually took the drug or the antibody for 5 years. And we see that, you remember I told you that half of the patients in the clinical trials had a greater than 50% reduction. Well, here it's 69%. And about a third had a greater than 75% reduction. Well, here it's 48%. So the longer one stays on therapy, generally speaking, the benefit can grow over time. How about side effects? Well, we've seen some new side effects, and we've seen a higher rate of the side effects that occurred in the clinical trials. So new side effects that have been reported by a variety of different doctors around the world include dizziness, fatigue, muscle cramps, joint pain, fatigue, sometimes even more headache, nausea, and sometimes hair loss. Now, these are not common at all, but they can occur, and they weren't really reported in the clinical trials. And then constipation, I mentioned, was seen in about 1 to 3% of patients treated with aranumab. It occurs at roughly 13 to 43% when one really looks for it in clinical practice. Rarely is it serious, and rarely does it lead to complications, and uncommonly does it lead to discontinuation, because oftentimes patients can get around it by modifying their diet or taking a stool softener, but it can occur. Now, the FDA, importantly, has updated the product information on aranumab. So anaphylaxis can occur, though it's rare, but it can occur. Hypertension can occur in people who've never had hypertension and in people who have had hypertension where it's made worse. Usually that occurs in the majority of people after the first injection and within the first week. We don't know how commonly it occurs because we don't often monitor blood pressure in that first week or in that first month after the injection. So we need to do more research on this. And severe constipation can occur, sometimes leading to hospitalization and sometimes in some patients even requiring surgical intervention. So people need to be aware of this important information. We have seen that the benefit may wear off before the next dose. So if you're a patient who's taken a subcutaneous injection every month, sometimes in the few days to a week prior to the next injection, the effect of the medication can wear off. And perhaps even in patients who have been responding for months or half a year or more, the effect can maybe wear off over time. That remains to be seen, but there's some evidence that that may be the case in certain circumstances with certain patients. Unfortunately, we can't predict who's going to respond. There's nothing about the particular patient that sits in front of me that I can say you're going to respond or not to these antibodies or to this antibody. And there's no way for me to predict what kind of adverse events that will occur. Although we're going to be looking, we always ask carefully about constipation now and hypertension. There are certainly patients who are pure non-responders. Just like there are patients who are super responders, there are patients who don't respond. In fact, we've had patients who don't respond to any of them, which is a bit of a disappointment. And why that is remains unclear, but clearly not everybody responds. And in pregnancy, I raised this issue earlier, but many of our patients are women of childbearing age. So it's really important to have a conversation about family planning with them, because if there's a plan to conceive, the patient really needs to be off the antibody for about 5 months. So now let's switch from the antibodies to the GPANs. The GPANs are drugs, they're not antibodies. And because they're drugs, they have a shorter half-life and have to be taken on a daily basis, usually by mouth. These drugs block the CGRP receptor. Like arenumab, you can see arenumab here as an antibody that blocks the receptor. These two block the CGRP receptor and not the protein. And there's 3 of them now: etogepant, rimegepant, and ubrogepant. Rimegepant and ubrogepant have been approved in the United States for the acute treatment of migraine, and etogepant and rimegepant are under investigation as preventive treatment. I'm going to make this short and simple by saying ubrogepant, which again is a small molecule as opposed to a large antibody, given by mouth. It's a drug, not an antibody or a protein. It's now approved based on a number of pivotal studies that were done that showed that about 20% who treat when the pain is moderate or severe become pain-free within 2 hours. And about 40% become pain-free if they're treating mild pain. So the quicker you can get on top of an attack, and the earlier you treat and the milder the pain intensity, the better the response. The relief of pain, which is going from moderate or severe to mild or none. So you can, when you talk about relief of pain, you can still have mild pain. About 60% do get relief of pain, which is typically what we see with the triptans. Nausea and dizziness occurred in about 2% of patients, which is a low incidence of side effects. So they seem favorably tolerated. In our experience now that we've been able to use ubrogepant, we looked carefully at the first 106 patients, and we were interested to know the proportion of patients who consistently got relief, because patients really need to be able to rely and depend on these medications when they take them. They need to know that whatever they're doing, they can get relief, they can get back to normal function, and they're not burdened with side effects. So essentially what we found is that the proportion of patients who 100% of the time will get relief of their pain after taking ubrogepant, it was about 30%. The proportion of patients who were pain-free within 2 hours, every time they took the drug, was around 12%. And then I've shown you the proportion of patients who more than 75% of the time had either relief or freedom from pain. Guess what? If you look at this number here, 30%, about 100% of the time, got relief of pain. That was about the same proportion of patients who reported being very satisfied. Not surprising. So about a third of patients who are taking GPANs consistently with every attack get relief of their pain and are very satisfied. Unlike the clinical trials, we've seen side effects in about 40% of people. Now, oftentimes they may be mild, and it's not, they don't discontinue the medication, but fatigue can be seen up to 27%, dry mouth, nausea, constipation, and dizziness. So we've seen more side effects, just like the antibodies. We've seen more new side effects that weren't reported in the clinical trials, and we've seen some side effects that were reported more often. Now, we treat a different patient population, of course. Most of our patients have chronic migraine, 95% of them. They were not included in the clinical trials. So it's a different patient population, but it's important to be aware that side effects may occur more often than was seen in clinical trials. Rimegepant is the other one. And roughly speaking, the results were exactly the same. 20% were pain-free, 60% or thereabouts had relief of pain, and again, very well tolerated, with nausea and dizziness occurring in 2% and 1% respectively. Rimegepant has also been shown now although this hasn't been published, a press release came out showing that it's, when used every other day, it's effective for the prevention of migraine as well. So here's the first drug class actually for migraine where it can be used both as an acute as well as a preventive treatment. The other important thing I'll highlight is that every acute treatment up until now that's used to relieve the symptoms of migraine, if used too frequently, like over 10 days per month, can actually lead to what's called medication overuse headache or rebound, where it increases the frequency of headache and migraine. These GPANs are just the opposite. The more often they're used, the more likely they are to actually reduce the frequency rather than potentiate or increase the frequency. And there's another GPAN called atogepant, which Professor Goadsby recently published on. This GPAN is, unlike rimegepant and ubrogepant, is specifically being developed for prevention. And you can see that roughly 52 to 62% were responders. They had a greater than 50% reduction in migraine days per month. If you look at 52 to 60% having a greater than 50% compared to the antibodies, which was 42 to 60%, it's roughly the same efficacy as we've seen with the monoclonal antibodies. Side effects, here you can see nausea 3 to 9% compared to 3% in placebo, constipation 1 to 4% compared to 1% in placebo, and so on, fatigue and decreased appetite. Now, whether when we get this drug, if it's approved into clinical practice, we're again going to see more side effects than what we've seen in the trial, and whether we're going to see higher rates of side effects than what we're seeing in the trial, only time will tell. But overall, relatively well tolerated. Finally, I'll talk about the DITAN. So I talked about antibodies and GPANs that target calcitonin G-related peptide. Triptans, which have been around for 30 years now, were designed to constrict blood vessels. So they bind to a serotonin receptor that's located on the blood vessel. It's so-called 5-HT1B. 5-HT really just stands for serotonin, B for blood vessel. They also bind to 5-HT1D receptors that are on nerves. So it was thought maybe we could just target the 1D or the 1F receptor that's located on nerves and not on blood vessels and get the same effect with those drugs as we do with the triptans, but avoid the potential for constricting blood vessels. And so lasmiditan was a drug that was developed to bind to this 1F, serotonin 1F receptor. And here's the clinical trial, the 2 pivotal clinical trials that were conducted, showing that lo and behold, not only does it work, but they work as effectively as triptans, with freedom from pain and relief of pain rates that are very similar to what we would see with any of the most effective triptans. Side effect profile, because this drug gets through what we call the blood-brain barrier and gets into the brain more readily than other drugs and certainly the antibodies, we're seeing more central nervous system side effects such as dizziness and tingling or numbness, and somnolence, fatigue, lethargy. And we see this certainly more commonly with this drug compared to placebo, to the extent that in the United States, the DEA has ruled that you cannot actually administer this drug if the patient plans to drive within the next 8 hours. So patients who take this drug cannot drive within the next 8 hours because of these sedative and CNS side effects that can occur. So what's next for patients? Well, what's next is taking another target beyond CGRP that appears equally important in the biology of migraine. And PACAP38, which I talked about, which is released from these trigeminal nerve fibers when the nerve is activated, appears to be equally as important a target as CGRP. But time will tell if targeting that protein or its receptor is as effective as the antibodies and drugs that target CGRP. Unfortunately, at this point in time, one of the antibodies that targets the PACAP receptor, or one of the PACAP receptors, failed to show a benefit in a clinical trial. But there's a new antibody that targets the protein rather than the receptor, because this protein binds to 3 different receptors. So maybe just targeting the protein rather than just one of 3 receptors is a better strategy. So we're enthusiastic and eagerly await the results of the clinical trials that show whether or not this different target is going to be effective if blocked for the treatment of migraine. because as I said, there are patients who don't respond to any of these antibodies. And so we need more new targets and more new drugs for people with migraine who don't respond adequately to conventional therapies that we currently have or established therapies, as well as these new antibodies. So I want to thank you very much for your attention. Again, I want to thank Professor Goadsby and the organizing committee for the opportunity. And I really look forward to fielding any questions that you might have and doing my very best to try to answer them. Look forward to seeing you. Thank you.
Lovely. Thank you very much for those lovely, well, very interesting talks from Dr. Afridi and Professor Dodick. What we're going to do now is move into our second period of questions. As I said before, we had a couple of questions in the first session, which we have held over for this session because our panel we thought might be better to answer them. We've since had a lot more questions come in, so we'll, without due cause, we'll move on to the questions. Okay.
Well, we might take one straight for Shazia there.
Yeah.
Shazia, someone's asking, is there a link between endometriosis and migraine?
Yeah, so there appears to be an overlap in that if you have endometriosis, you're more likely to have migraine as well. Both are quite common conditions, of course. So endometriosis affects about 1 in 10 women. And of course, migraine, about 15% of the population, and even higher in women of childbearing age. So we don't really understand why they're linked and where the hormones fit in, etc. But there does seem to be an increased incidence of women with migraine having endometriosis and vice versa. Yeah.
And you touched this a little bit on discussion around the menopause. Someone's asking someone in their 60s and the relationship or interaction between migraine and using estrogens in their 60s, presumably as hormone replacement.
Yeah, I mean, generally, when women are on HRT, they don't tend to go past 60. I mean, the recommendation is usually sort of between 50 and 60, you carry on using HRT. And then if you're using it above the age of 60, then there are other risks that are involved associated with HRT. So with regards to migraine at that point, I guess I would then sort of move away from the hormonally based treatments and go back to the original classic kind of preventative treatments one would use in other people of other ages, of age groups. They wouldn't specifically be a targeted hormonal treatment for people over the age of 60. I would think it's more sort of people around their mid-40s, mid-50s, up to the age of 60, where you can target things around HRT, I would think, and it's less advisable to use HRT when women have hit 60 for other risk factors and things with, for example, risk of breast cancer, etc.
Thanks.
Shazia, we've got another one coming which says, is it common to get migraines in weeks after periods? And also another one which is sort of, my migraines got quite worse after having my first child. Since then, I've been unable to manage them and none of the preventatives work. Is there anything I can do to help that?
So the first question about migraines after your period. So we know that the hormonal levels of estrogen, well, the estrogen level changes throughout your menstrual cycle. So at the period, it's very low, and then it slowly starts to rise, and then it's higher around the mid-cycle. So any time between 2 days before the menstrual period up until about 2 weeks into it, the woman is more vulnerable in terms of having a migraine trigger because your estrogen level is lower. So yes, it's quite common to have migraine the week after the period, even it doesn't have to be during the period. Of course, people have other triggers for migraine. It's not only menstrual triggers that occur, and obviously that, if you're not sleeping well and missing meals and stress, etc., that could also be a factor. But from a hormonal point of view, yes, the estrogen is still lower at that point. So yes. the second question, sorry, remind me what the second question was again. That was about getting more migraine after the first pregnancy. Is that right?
Yeah.
So in the postpartum period, again, we know that estrogen drops suddenly, and that makes a woman more vulnerable to having a quite rocky period. And that, in combination with the fact that you've got a newborn child, you know, you're not sleeping well, you're missing meals, you have stress. These factors can make your migraine worse. Eventually, that should settle, however, as the hormone milieu sort of tries to settle down and your lifestyle settles down. That, from a hormonal point of view, should settle down and shouldn't really trigger an ongoing period of migraine. But, you know, if you can have multiple factors involved, and it may be that all those factors combine together, leading to you developing more frequent migraine, which then can become more chronic. And then we know if someone develops chronic migraine, they might be taking more painkillers, for example, and you might develop analgesia overuse. There's a whole sort of vicious cycle. You may become more sensitized as well. We know that people become very sensitized when they have a lot of migraines. So there are multiple possible reasons for that. How you'd manage it? Well, at that point, once everything is settled down, I would manage it using the same medications I would with somebody else. I wouldn't specifically target any hormonal element in that particular case, I would say.
So David, there's a couple of questions we've had, one earlier and one now, about the use of the CGRP monoclonals in people who've had heart attacks in the past. Before you answer, let me congratulate you on a splendid Migraine Trust lecture. For those listening, the Migraine Trust lecture itself is one of the two feature lectures of our meeting, and we had the pleasure of David giving that lecture this year. So it's I'm really pleased that you could come back and reprise the topic here. So in monoclonal antibodies in the context of someone who's had a myocardial infarction.
Right. Thank you, Peter. And let me take the opportunity to thank you and the organizing committee for such an honor. I mean, the people who have come before me that have given the Migraine Trust lecture are really the best in the field. And a lot of wonderful historical figures have given that lecture. So it's one of the highlights of my career to be able to give that lecture. So thank you for that opportunity.
Thank you.
And the question is a good one. There has been speculation that perhaps, even though the antibodies do not constrict blood vessels, they do block a peptide, CGRP, which dilates blood vessels. And so is it possible that in the context of someone having a heart attack or a stroke or an episode of angina or a transient ischemic attack, could it make the situation worse by preventing those vessels from dilating when they really need to dilate? So far, in clinical trials and in clinical practice, to the best of my knowledge, I obviously don't have knowledge of everyone who's been placed on an antibody, there hasn't been concern that these antibodies have led to a myocardial infarction or heart attack or stroke. Now, so the question is, would I use it in a patient who's previously had a stroke or a heart attack? And my answer to that is depends. I have.
well, that's a great answer.
Yeah, I know. It really does depend. So I'll give you an example. I had a woman who had a coronary artery dissection and had a heart attack. And CGRP appears to be very important in women in particular, especially when it affects small blood vessels in the heart. So I actually decided not to treat her again with a CGRP. But let's say I have a middle-aged or a male who's had a myocardial infarction in the past. And let's say they've had a stent placed and their heart function is normal and their vessels are open. Yeah, I would use it in a patient like that because I'm not so worried about precipitating another heart attack. And the evidence that it's going to worsen a heart attack or increase the size of the heart attack or stroke is really just speculative right now. So I actually look at these new drugs, including the receptor antagonists and the antibodies, as an opportunity to expand the therapeutic options for patients who do have cardiovascular risk factors in whom we really shouldn't be using triptans or NSAIDs. So it expands the clinician's therapeutic arsenal, and certainly it provides more options for the patient. So my answer is generally yes, with few exceptions.
Of course, CGRP is one of a family of peptides that we've learned about, and the beauty of these monoclonal antibodies or the GPANTs is the fidelity, the specificity of what they do, so they don't affect other peptides receptors like adrenomedullin. There's backup in the system, which makes things.
Yeah. So that's an excellent point, Peter. Thank goodness we're not, since dilation of blood vessels is so important, we're certainly not going to be relegated to just one peptide that dilates blood vessels. So yes, that specificity is really key. And to think that all these other mediators, proteins, peptides that dilate blood vessels, and it's going to come down to just one, is, I think, rather naive. So it's an excellent point.
And someone's asking, they've had a number of treatments in the past. They mention up to 9 treatments for chronic migraine, currently on botulinum toxin, and it's not going as well as it could do. What's your experience in patients who've had multiple preventives and even not responded to botulinum toxin, who've got chronic migraine, moving on to the monoclonal antibodies?
Yeah, it's a good question. So we've actually looked at this in our practice, and in our patient population, 95% of whom have chronic migraine, in whom we've used these antibodies. And on average, they failed around 10 prophylactic medications. So far beyond what we see in clinical trials where they failed 2 to 4. Despite that, the response rate in our practice is around 60%, 55-60%. So that's good, because these are really treatment refractory or have been, they've had disorders that have been challenging to treat. Now, the issue about botulinum toxin, when the antibodies were free in the United States for patients and they could get access for a year, we certainly added a lot of patients who were on Botox to the antibody. So we added the antibody, they were on Botox, and Botox maybe was working partially. They really weren't getting a whole lot of benefit from it, hence the reason to add the antibodies. In our experience, and I think this experience has been shared by others, patients on both tend to do very well, actually. So if you're getting a partial response to Botox, adding an antibody, we believe, is both safe, because these Botox is not really systemically absorbed. There's no drug interaction. There's no reason to believe there would be any interaction. So it's safe, they're well tolerated, and there seems to be some sort of synergistic or at least complementary effect of people who are getting a partial response to one, adding the antibody to it. Now, of course, cost and reimbursement and access to both is an issue. But if it weren't an issue, and I've had a patient who responded partially to either Botox or the antibody, would I add one? Absolutely. And we've had good success doing that.
Very helpful.
We've got quite a few questions coming in on magnesium and things, vitamins that might help migraine. And also one is concerned, would they be able to take it during pregnancy? And does it work, in fact? And do you have to be on it for 3 months, say, before it will make a difference?
So this is magnesium in pregnancy, isn't it?
Magnesium, yeah.
Yeah. So magnesium has often been used in pregnancy by obstetricians for other reasons anyway, so women with preeclampsia. So it's been used for a while and has thought to have been relatively safe. There was a study looking at women who've used large doses of intravenous magnesium for in a hospital setting, and that did have some effect on fetal bone development. So, as everything, nothing is entirely safe, but I think the doses that you would use for migraine prophylaxis and oral doses so far are thought to be relatively safe, although I guess there are not large numbers of studies done on that. And how long you would use it for, I guess, well, usually in pregnancy, migraine tends to get better towards the end of pregnancy. So it's usually the first trimester where there's a rocky period anyway. So if you're using it, you would use it, I guess, probably for the first trimester, and then wean yourself off if you think that things are getting under control, because a lot of women find that as the hormone estrogen levels increase in your second trimester, the migraine also improves spontaneously anyway. With regards to vitamin B riboflavin, so in the doses that are given in standard multivitamin tablets, those are thought to be safe. But in migraine, the doses that are used are much, much higher. They're supramaximal doses, and we don't really have evidence that that is safe in pregnancy. So I'd be very cautious with using those extremely high doses of riboflavin during pregnancy. There's no clear evidence of that. Things like coenzyme Q have also been used in migraine, and certainly after 20 weeks, there is some evidence that they can be used safely, because again, they've been used for other indications. But I would wait till after 20 weeks with coenzyme Q.
So there's a question about bioidentical hormones, Shazia. Are they useful in managing menstrual migraine?
So I guess there are different definitions of what you mean by bioidenticals. There are some regulated hormones, and there are some that are unregulated and sort of claimed to be natural hormones. And so there isn't good evidence for that, as far as I'm aware. Some of the HRT hormones that are used are derived from natural sources anyway, so those are fine. But I think there are different practitioners prescribing various bioidentical hormones, which I'm not really sure if there is evidence to say that they're any better than the non-bioidentical ones. So I think that's probably not, there isn't much evidence there, I would say.
There's a question about triptans over the 65, so I'm going to take it, say something about it, and then pivot to David to comment on it in the context of lasmiditan, the dietans. So the question is, can triptans be used when you're over the age of 65? I mean, the answer is yes, with the proviso that you understand that the license has restrictions. So the license went up to the age of 65 because when the studies were done, that was an age limit. That was where the age limit was placed on the studies, largely to keep things safe. I think over the last 25, 30 years of experience with the triptan, it's pretty clear cut that it's not about age. It's about cardiovascular, cerebrovascular fitness. So if you're a 40-year-old who's overweight, smoking, cholesterol, hypertension, history of heart disease, that's a problem if you want to use a triptan. Whereas if you're 69, jogging around the block, good weight, good blood pressure, cholesterol controlled, no particular family history problem, there's no reason to be concerned about using a triptan necessarily. So it's not, age is a legalistic thing developed out of the trials. It's not a physiological, it's not a body thing. So I think it's very important as people, it's important at any age to judge the use of the medicine in the context of the person that you're giving it. I have many patients over the age of 65 using triptans, and I think it's absolutely perfectly fine and dandy. And it leads into this question of cardiovascular disease if it's there, and the dietans, lasmiditan, and you talked about that a little bit, David.
Yeah, it's an important issue, and it's certainly good to have in the United States, where the medical legal system is precarious. Yeah, you have to be careful. If the label says that triptans are contraindicated in patients who have established cardiovascular disease, then they're contraindicated. And regardless of whether I think they're safe or not, because in 30 years of prescribing triptans, I've never had a patient have a myocardial infarction that anyone thought could have been caused by a triptan. Not one. And I've lost count a long time ago how many times I've prescribed these drugs, including in patients with multiple cardiovascular risk factors, by the way. So these drugs are very safe, I'm here to say. But and in fact, to be honest with you, I worry more about the 45-year-old woman who has Raynaud's disease or Prince-Metal's angina or something like that, where their vessels, where they have vasospastic disease. I worry more about that patient than the 69-year-old man who has coronary artery disease and had a stent. So, but the fact is you cannot use triptans in these patients, at least according to the label. So having a dietand, for example, lasmiditan, which does not constrict the blood vessels whatsoever, that's great to have for our patients, because I can prescribe that then without having to have a 10-minute conversation with them about, the liability of using this drug and that it's contraindicated or that we have to be careful. I don't have to have that conversation with the patient, and I don't have to have the concern that this patient is going to have a heart attack due to the drug or have a heart attack which could be attributed to the drug. So having, and that goes for the G-pants as well. So I can prescribe these relatively liberally to these patients without much concern. So it's fantastic to have drugs where we've moved away from the blood vessel entirely, really. We no longer need to constrict blood vessels, nor did we probably ever, to get relief of pain and associated symptoms. So it's wonderful to have these, and they do provide a nice option for patients, regardless of, the actual risk taken by a patient when we prescribe a triptan. It's nice to be able to provide them with something that provides perhaps just as good efficacy, but without that risk.
I think it's fantastic that and we say this not based on like opinion or guessing or crystal ball work. It's clear, as you said, that the ditans, lasmiditan, don't have any action on blood vessels, full stop, new paragraph. You can do these blood vessel baths where you put the blood vessel in a bath and you put the ditan in the bath, and the line's flat, dead flat, as in nothing happens. And there's nice work coming out of the Netherlands, Antoinette Masson van der Brink, showing that if you put the ditan with a triptan, it doesn't affect what the triptan does either. They just don't interact with each other. And it's fantastic is that we understand why, we understand how to build these medicines, and then they work and they're safer. It goes to show you that, I like to say it, but research works, and it has value.
Funny about that.
Yeah, funny thing that. Exactly right. Exactly. Did you want to? Should we move to another question for?
Yeah, we had a question earlier. We thought you might be able to help us with this, David. I've spent many years trying many different medications which have not worked. Then I tried stems by eNeurowitch and has been life-changing. But unfortunately, eNeuro has gone bankrupt, and I am using GammaCore, which helps but is not as good. Is there anything that you could do differently?
Yeah, so there's a number of devices on the market. I too have had patients for whom the transcranial magnetic stimulator from eNeuro had been, life-altering, including some employees at my own institution who were emailing me and texting me and calling me when eNeuro did go bankrupt, and what are they going to do with the device, and what are they going to do now? And it's unfortunate. I don't think necessarily when you have an approved device for both the acute and preventive treatment of migraine, I suspect that somebody's going to pick that up. So I'm optimistic that in the future we're going to see this technology and this device back, because it's just not fair to patients to have something that's safe and well tolerated that works, even if it's for a proportion of patients. It's not fair that those patients can't have that. So I'm optimistic that we're going to see it come back. But GammaCore is not working as effectively. There are of course, two more devices that are being used. One is this remote neuromodulation device from Theranica, which is an armband essentially that provides electrical stimulation over the arm. It's for acute treatment, not for prevention, like the eNeuro device could be used for. And it has to be applied for a longer period of time rather than just a couple of seconds. But that's another option. The GammaCore, of course, is one option, and the Cephaly device, I think out of Belgium, the company's in Belgium, but the Cephaly device has been used for some patients effectively for both acute and preventive treatment. So there are other neuromodulation devices, and I will tell you that there's quite a pipeline here of new devices that are being tested now in clinical trials. Devices that wrap around the head and stimulate the entire head, to devices that you put an earbud in your ear and it stimulates the eardrum and may provide relief. So, and there are others. So there's a whole slew of devices that actually now that are in clinical trials. So I'm sorry for the person that had a life-altering effect from the eNeuro device, but remain optimistic that we're going to see this back in the not too distant future.
Yeah, we've had the same experience. It's really irritating when, to say the least, for people when something works really well and then the rug gets pulled out from under them, and that device is so has got a lot of utility. I mean, because it's safe in pregnancy, for example. So it's just so irritating. As you say, it's proven, so I think it'll come back.
I think it'll come back, but here's where we really could use patients' help. The problem is the system is broken when it comes to reimbursement and coverage for these devices. They're too expensive and insurance doesn't cover them. And we really could use patients' help, mobilize to fix what is a broken system. That company would not have gone bankrupt, and we probably would have more devices on the market now were it not for a system of reimbursement that's clearly broken when it comes to devices.
Certainly. Shazia, there's a question around naproxen use in menstrual migraine, and it builds around medication overuse. So if you're using naproxen for menstrual migraine and you do that every month, can that lead to medication overuse?
I've not seen any evidence that that does lead to medication overuse. Firstly, out of the medications that are associated with medication overuse, headache, the codeines and the opiate-based are the worst. Paracetamol can also do it. And actually, the group of drugs that naproxen belongs to, which are the non-steroidal anti-inflammatory drugs, are probably the least likely to be associated with medication overuse headache. So that may be a reason why. Also, you're only using it for a period of, say, a week, and then you're stopping it for the next 3 weeks. So it's not that you're continually using it for a whole month period, which would be a problem. So I think for those two reasons, I don't think it's associated. It's not been shown to be associated with development of analgesia overuse.
And someone specifically asked the why question about naproxen. Why after 32 weeks gestation, if it's safe in the rest of pregnancy and during lactation?
That's to do with fetal development. So around 32 weeks, there is a blood vessel that links the right and left heart of the fetus, and that closes. And that's to do with these chemicals, prostaglandins, or things that the drugs can inhibit. So any drug that is in that group of drugs called the non-steroidal anti-inflammatory drugs, so ibuprofen, naproxen, diclofenac, and aspirin, they should not be used after that 32-week period.
The patent ductus, yeah. David, sorry, Mike.
There's also some questions about other preventatives, which are coming about. Propranolol being used for several years as a preventative, but the person was still getting migraines. Recently, the GP moved them on to pizoxifan, and desongestrel appears to be linked with hormones as well as propranolol. They seem to be working so far, but is that okay to sort of, is that a good combination in terms of long-term use?
Sorry, was that the question? Was pizoxifan and or what? Sorry, I didn't.
Desgestrel.
Sorry.
Desgestrel. Yes.
Okay, so and there was the relation to pregnancy. Was the question? No.
No, it appears to be linked with hormones as well as propranolol. Nothing about pregnancy. They seem to be working so far, but is that combination a good combination for long-term use?
That's fine. Yeah, pizoxifan is an established anti-migraine preventative drug. It's fine to be on that with a contraceptive. Yeah.
Someone's asking, can migraine be triggered when you have a prolactinoma? Shazia.
Well, yeah. I mean, so again, prolactinomas are benign pituitary tumors, so they're releasing hormones. Prolactin can result in other hormones being raised as well, so it has a sort of knock-on effect. There was some studies I think done with pituitary tumors in general. I had a chap called Dr. Miles Levy. He was working with Peter Goadsby. We did a lot of work on this, looking at headaches occurring in people with pituitary lesions. Interestingly, the headaches that come on when people have prolactinomas are migraine, and they look like migraine, and they actually behave like migraine, and these should be treated the same way. Obviously, if someone has what we call a functioning tumor, then they may need other medications from endocrinologist to try and reduce the level of prolactin as well. But yeah, certainly you can get hormonally related migraines triggered by that. There aren't really good studies specifically looking at which particular hormones are triggering them. I think that's probably some interesting research that one can do. But yes, I think it could be a factor.
Frank Price has actually done some nice preclinical work, as you know, Peter, showing that prolactin is a potent activator of these nerve fibers, trigeminal nerve, pain nerve fibers. So there's a sort of a pathophysiological link that's been shown now, at least in animal models, where as to why prolactin could actually activate this sort of migraine pathway, if you will.
I'm sure it's a thing. Defining it is more complex. We're in the last minute, David, so I'm going to toss you a complex question to answer in 30 seconds. Are there any medications that are contraindicated to use with either the monoclonal antibodies, the CGRP, or GPANs?
Good question. So there are no contraindications to the use of any medication with the monoclonal antibodies because they're proteins, they're broken down like other proteins in the body, they're not metabolized by the liver, and that's one of the beauties of them. You can combine them, you don't have to worry about drug interactions. With the GPANs, with one of the GPANs, ubrogepant, you just cannot use them with drugs that are metabolized by a certain liver enzyme, particularly antifungal medications. So other than that, if you're not on an antifungal medication, you don't have to think about the GPANs or the monoclonal antibodies.
Well, thanks, Van.
Thank you very much.
Thank you both for getting into our last.
This session.
Thank you so much.
Thank you so much for Professor Dodick and for Dr. Afridi for those presentations.
Thank you.
Thanks.
Well, thank you for those of you who've attended. I think we've had an opportunity to get across a range of topics, from the practical advice that Dr. Rusk gave you through to particularly talking about migraine aura with Allan Purdy, the hormonal aspects with Shazia Afridi, and then the new and exciting medicines that David Dodick spoke about. The Migraine Trust is about making the world better for people with migraine and the other primary headache disorders, and research is a core part of that. That's why we put on the symposia every 2 years. As I said, we had a broad attendance. We've had more than 2,000 views of our educational material already, and I hope that we've been able to distill some of that for you today so that you could get an idea that there are people working really hard to understand this problem and to give you better treatments and make things better going forward. It's not perfect, but we're trying to improve it year on year. And with that, I'll hand over to my co-host and trustee, Mike Wakefield, to bring us home.
Thank you, David. I'd also just like to say thank you for all the speakers, and also actually a big thank you to Professor Goadsby for his drive in making the International Symposium happen, and for his personal desire to improve the lives of migraine sufferers like myself. He's a great advocate for migraine throughout the world. Also recently been going on to our popular daily program this morning and doing a headache clinic live on air. Well done, thank you. Many of you who have joined us today will already be supporters of the Migraine Trust, and you will know, like all other charities, we are facing a challenging period right now. And I just ask you to consider donating to the Migraine Trust and maybe considering a regular contribution to us. We're doing some fantastic work now. You'll get a newsletter comes out twice a year and covers many of the subjects which have been raised today. It's a great way to keep abreast of everything that's going on in research and in the help that we are able to give to the patient community. Also like to give a very big thank you to our hardworking and dedicated staff team. They are working tirelessly at the moment in very difficult circumstances, usually working from home to keep everything running, and they're doing a fantastic job, and a big thank you to them. And finally, basically, a big thank you to everybody that's joined us today. It's been a new format for us. It's been interesting. We've had more people join us, which is a very good, real positive from it. And I hope you've enjoyed the stimulating and educational presentations which we've been able to bring to you. We will be probably sending out a questionnaire on just to get your feedback about how you liked the day, how you liked the presentations, what you would like to do differently in the future. That would be very helpful feedback, because I think we'll probably do more, if not exactly like this, but we'll do more of these. And basically that's it. That's just a big thank you for joining us, and goodbye and enjoy your Sunday evening. Thank you.